Hello, I'm Travis Nelson, and today we're going to be doing a discussion on dental caries in children. This is a topic that I'm asked about frequently, so I thought I would provide some perspective from me as a pediatric dentist and a clinical associate professor at the University of Washington to you, most likely a practitioner in primary medical care or pediatrics. So without further ado, we'll get on with this presentation. And the first way I'd like to start out with is a question. And the question to you is, how many teeth are in a mouth? Now, the reason that I'm asking you that question is because I've asked it so frequently to residents who have come and visited us in my dental clinic. And when I ask that question, invariably they'll respond to me either 20 or 32 or perhaps 28, all of which are correct answers. And then my follow-up to them is, how did you know that? And they say, hey, listen, this is all I was taught in medical school, very little else. But I think I know that because I was taught in anatomy that there were 20 primary teeth, 32 a total complement of adult teeth, or perhaps 28 if you were missing or had extracted wisdom teeth. And I'm always impressed by that and amazed by it, but I'm also the follow-up from the residents and from other practitioners who I've spoken with in the past is pretty universal. Don't ask me too many more questions about that because I didn't get much exposure in my education or my training. My next question is, what about all your patients, your little ones? Of course, I think you would agree that it's important that they have regular and routine ear examinations, that we check and listen to their heart and lungs, but somehow the teeth have made their way outside of the body. And so part of my goal as a dental practitioner is to help our medical colleagues to understand a little bit more about teeth and their role that they play in the body. But to redirect our conversation today more to the idea of caries. Now, when I ask audiences and practitioners when I'm speaking one-on-one with them about cavities, sometimes I'll ask, did you ever have a cavity as a child? And many of us have. Many of us don't really remember it much because this is what it looked like. You went in and maybe the dentist diagnosed that there was a cavity between the teeth, and then they drilled it out just like this, put a little matrix around it and a wooden wedge, a dental dam. They filled it up, and like the bottom image there, you can see that it was kind of a non-event. But not every child has that experience. And in fact, unfortunately, many children, the situation is much more dire. So I've put in a warning slide here. This is based on feedback that I've gotten in the past that said that Dr. Nelson really shouldn't show disgusting pictures of teeth without providing a warning. So here's your warning. I'm going to show some pictures of teeth that may be a little bit gross, and if you're squeamish at all, feel free to stop the presentation whenever you like. So the problem is that for many children, the situation that is brought on by dental caries is much worse than that simple restoration that was seen in the previous images. Sometimes we have children like this. This may be an extreme case, but I presented it here because you can see this is a child who's not even 3 years old yet, and yet they've had complete destruction of the hardest substances in their body from tiny little bacteria. And when you look at this, you can see a fluctuant abscess or 2 or 3. And then you can also actually peer directly into the pulp chambers of the tooth where the nerves are. Obviously, this is a child who's going to have a hard time eating healthy foods. They may have fevers. They may have infections that spread beyond just the immediate areas around their teeth. And it's hard for them to do normal things like going to school and sleeping and eating. So really a serious problem. Another component of this in pediatrics that we always think about as pediatric dentists is we have a tooth and a dental problem to address, but there's a small patient who's attached to it. So you can see here one of my patients, she's sweet, she had no problems actually in her mouth, but if she did, at this age, would she allow us to have her to put that dental dam on, to give an injection and do a restorative procedure multiple times? And the answer for most youngsters is probably not. And so ultimately, this can result in children having sedation and, in this situation, general anesthesia to address those severe dental issues. Now, this is a very effective way to address this, and it's something that I do regularly in practice, in particular because we have a lot of severe cases come through the university. However, it's not something that should be a goal of ours. And in fact, we know that it comes significant cost associated with this, as well as risk. So it's something that we should try to avoid if at all possible. I do also want to pause and say that, oftentimes I get questions from colleagues and also from parents. These are just baby teeth. Do we really need to fix them? Do we really need to do anything about them at all? Perhaps we can just wait till the permanent teeth come in. But the truth is that primary teeth are really important. And there's four key areas that I at least would think about when we're assessing the importance of primary teeth. The first is that primary teeth are needed for good nutrition. All the foods that you're recommending to your patient, healthy foods like carrots and apples, things that are crunchy and nutritious, you need to have healthy teeth in order to eat those. If you don't, imagine that child with the images that I showed previously. It'd be a very big challenge for them to eat healthy foods. They're also needed as we develop language. So for example, you'll see in many of the images that follow, the maxillary anterior teeth are the ones that first develop caries in most situations. In fact, I've probably extracted more maxillary incisors than any other teeth in my practice. It's because those teeth are some of the first to emerge into the mouth, and they're the most susceptible to the caries process. So when we extract those, it can be challenging for children to pronounce words like tooth. If you think about that TH sound, we need to place our tongue on our incisors in order to create that. Now, these children will ultimately be able to develop language, but it can set them back a ways. Another thing that's really important is that the primary teeth are really the key placeholders for the permanent ones. So it's common that when we extract a molar tooth on a child, that the rest of the teeth will shift forward. What ultimately results is the permanent teeth that are still waiting to come in, they're up there in the bone, those permanent teeth will be pinched out or not have enough room to come into the mouth. And so in this situation, we end up with orthodontic problems. Unfortunately, many of the patients who have this happen may not have the resources to pursue orthodontic care as adolescents and adults. And the last and one of the most important reasons that we want to address the health of primary teeth is because we want to reduce the risk of having that disease in permanent teeth. We know children who have severe dental disease early on in life are very likely to have that later in life as well. So these are all really important things and reasons that we value primary teeth. We're not going to spend much time on this today, but just as sort of an introduction to the idea of tooth development, we know that primary teeth first come into the mouth by around the age of 6 months, and I believe some children are actually even born with them. A natal or within the first 30 days of life would be a neonatal tooth. Over the course of the next 30 months or so, they'll begin to get the full primary dentition, which is 20 teeth. And then those teeth will start falling out probably around age 5, but that can vary considerably depending on the child. So here we have an image of healthy primary teeth. These are two mandibular central incisors, the first teeth that most children get. So that happens oftentimes by around the 6th month of age. And then you can see here another child, probably between 10 to 12 months of age. And this is exactly what we're looking to see in a baby's mouth. As we progress further, this is a child who's probably 3 to 4 years old. As I mentioned, usually by month 30, the child is going to have a full complement of primary teeth. And I like to show this image, one, because it's got a great kind of a textbook set of primary teeth. Great bite, very healthy, no evidence of caries. But it's also got something that's a little bit unique, and I get questions about from my colleagues. And that is the child has a dark complexion. And you can see this in the line that surrounds the tissues that are supporting the teeth. And that's because those tissues are keratinized. And with keratin, we also have melanin. So you can see that darker line adjacent to those teeth. But then apically, or sort of above and below the teeth, you have more of that pink mucosa. That's the unattached, more of a loose tissue that is very common pretty much with all patients of all different types of complexion. So getting back to caries, that's just sort of a little bit of an introduction for us. But getting back to caries, I want to give you sort of a high-level overview of what this process looks like. And to do that, I have a little video. It's going to go pretty quickly here. But in this video, you're going to see caries progress from the outer layer, that very white layer, which is the enamel. into the dentin, and inside the dentin, it's less mineralized, much more organic, and then it'll proceed into the pulp of the tooth. So we can see it now progressing as I indicated. Once it's entered the pulp chamber of the tooth, that's where the nerve and the blood vessels are. When it gets into there, there's nowhere that inflammation can go. There's nowhere it can expand. And so ultimately what it does is it squeezes that nerve, causing the tooth pain that we know to be common with a dental infection. And then also you can see that here it exits the tooth into the alveolar bone that supports it. Now this can result in bone destruction. It can result in a localized infection like an abscess, or in a cellulitis that can become more serious. So this started in the enamel, and the initial dental caries lesion is the white spot lesion. You can see that here in this image. Those white spots are a band right along the gingival margin. And that's where we generally will see the bacteria living, and if not cleaned off regularly with a toothbrush, will proliferate and have acidic challenge. The acid, in turn, will remove minerals from the teeth, and when minerals are lost, it changes the way light bounces off of this, refracts in the tooth, and you can see a change from sort of that pearly color to more of a matte white. We call that the white spot lesion. If it's left unchecked, this will progress to cavitation when that enamel becomes so fragile that it breaks. And here you're actually looking at the inside or the middle layer of the tooth, the dentin, which is much more yellow. If that progresses, it becomes a cavitated lesion. This is obviously something that will need to be addressed, either with some types of more modern fluoride treatments or with a dental restoration. And then we see this has progressed to a much more severe case where these teeth are essentially non-restorable and are probably causing the patient quite a bit of pain as well. I will note, I mentioned those maxillary incisors are almost always the first ones to develop caries. Look at the mandibular incisors immediately below them. These teeth are the least likely to develop caries. It's because they're regularly bathed in saliva, because their salivary glands dump fluid over them constantly. And the tongue may protect them from things like the nipple of a bottle that may release sweet liquid. So it's quite uncommon to get caries in the mandibular incisors. If you do get it there, you almost certainly have it in many other teeth as well. As I mentioned, this caries can lead to cellulitis, which is a very, very severe thing in a young child. This patient had significant caries and infection in an upper right maxillary primary molar, which resulted in this level of infection. The tooth needed to be extracted, and the patient was placed on at least a 2-day course of IV antibiotics in the hospital. So a significant issue, and one that I'd like to really emphasize again, is entirely preventable. So I've found in my work with pediatricians, with my physician colleagues, that it's helpful to look at pictures. So we'll go through a few now. So in these pictures, you can see, imagine where that white spot was in other images. That has ultimately broken away. The enamel has broken away, and now we're looking at the dentin. You can see in this image, the incisal edges of those maxillary incisors is entirely intact because it was not affected. In this image, you can see the teeth have essentially dissolved all the way away. And then on the patient's upper right there, we have a little parulus or a fistula, an area where that infection has been draining. This is one of the first images I showed earlier in the presentation, but it's really such a significant one that I would show it again. We've got two areas here that are clearly infected. And then if you pay attention to the patient's upper right lateral incisor, you can see you're actually looking down into this patient's pulp chamber, which means that nerve has been exposed. Obviously would be very, very uncomfortable for that patient. I like to show this image because you have darkened teeth in this one. We have a newer agent in pediatric dentistry, or in dentistry as a whole, called silverdiamine fluoride. It's a powerful fluoride agent that can be applied very specifically into areas where there's active caries. In this area, we applied that, and then it stops the cavity process, or it arrests caries. And so these teeth may look to be, severely, decayed and problematic, but they're probably much less concerning than a tooth that has more of a yellow or a brown active caries. This is something, as you're checking children's teeth in the future, you may see this, and it could be an indication that the child is actually pursuing dental treatment and have chosen a more conservative approach than restorative dentistry or extraction. Just putting in here a little check. This is an image where we have a child who has a perfectly healthy dentition, but they have a little bit of space between their incisors. Question I get fairly frequently from colleagues is that, is it okay to have that gap? We call it a diastema in dentistry. And of course, it's great. We like to see this because the primary teeth are going to be more narrow than the permanent teeth are. And with the more narrow primary teeth, if we have spaces like that, it generally will facilitate the eruption of a more straight adult dentition. Moving on, I mentioned to you that you really have to work to get cavities in those mandibular incisors. Well, here's a patient who did, and you can see there's that hole between the mandibular central incisors. This is a case of a patient who had significant decay throughout their entire mouth. And of course, you can see here above the root of the patient's maxillary left central incisor, we have another one of those little parulus or fistula indicated in the soft tissues. So I'm showing you here a tricky image, and I'm doing this to really illustrate a point. When you see this, this is a very young child. The teeth generally look quite healthy. But if you pay close attention to this on the patient's right maxillary central incisor, it'd be the image as you're looking at it, probably on your left. There's a little bit of a darkening near the incisal edge of the tooth. If you investigate that more fully, perhaps with a mirror, you can see there's actually a pretty significant lesion on the palatal side of this tooth. And I use this image to illustrate the idea that oftentimes patients, this is a very likely place to get caries. And so if you're able to use a mirror or just turn your head so you can see the back sides of those teeth, that can be an effective way to do a more comprehensive screening when you're checking the child's dentition. So in summary, caries is a bit of a balance. We have things that can tip it towards caries progression or towards not having caries. The primary risk factors are going to be having very virulent bacteria or having lots of them, having low quality or insufficient saliva, which can occur when children are on medications. And then probably the biggest one is having poor dietary habits. Things that we can do to help protect against caries would be to have a patient who has good quality saliva, to place dental sealants when indicated, use of some antibacterials. Those would be things like chlorhexidine and sometimes iodine could be used in cases where patients have active disease. Looking at fluoride agents, both topically over the counter in toothpaste and professionally applied fluoride in a medical or a dental office in the form of fluoride varnish, most typically, and then having a healthy diet. Just to touch briefly on fluoride, we know fluoride is a really important component in this process. And if we can add that both topically, as I mentioned, with things like toothpaste or with water, and systemically, when the water is consumed by a young child, it goes into the developing teeth and it will make the enamel matrix less susceptible to dissolution with the acid that forms after the bacteria have been fed carbohydrate. Which leads us to the final thing that I want to talk on with regard to dental caries. And it's probably the most important thing, and I know it's something that you're speaking about with your patients, and that is diet. So there's one key thing that I really want to leave you with from the standpoint of dietary messaging, and it's this: frequency. I'll give you the example of two people. The first one is hypothetical. That first person only eats 3 times a day. Now, I know that nobody really eats 3 times a day, but just bear with me. Each time they eat, they're going to have a carbohydrate. When they eat that carbohydrate, the bacteria in our mouths or their mouth will take the carbohydrate, they'll turn it to acid, and then the mouth will become acidic to the pH of 5.5, which is the critical pH for dissolution of enamel. That happens every time they eat. However, probably within 20 to 40 minutes, the saliva in their mouth and just with time, it will buffer that acidic process and it will go back into that blue zone where the teeth are remineralizing. It's a normal and a natural process of homeostasis. Now, you can see another individual here on the right. This is an adult construction worker on a roof drinking Gatorade throughout the summer. It's an office worker drinking a sweetened latte all day long. And in our practice, This is a young child who has goldfish crackers and granola bars, and perhaps even the worst would be things like juice or other sweetened beverages in a bottle or a sippy cup. What happens in their mouth is that they consume these carbohydrate products, and they don't allow enough break in between for the remineralization to happen before they expose the mouth again. And ultimately, the balance of the process is that you have more acid or more time in acid for those teeth. Ultimately, there's not enough remineralization that occurs, and the teeth will break down. We saw that with the white spot lesion, the progression to cavitation, ultimately having teeth that are significantly destroyed and can lead to something like an infection, like an abscess or cellulitis. So I hope that this was helpful for you, and I have listed an email there. I'm always happy to get in touch with physician colleagues if they have questions about children's oral health. Thank you so much.